You are listening to Seniors Junction podcast. We are eliminating seniors isolation, one conversation at a time. Your hosts today are Dr. Namrata Bagaria and myself, Dr. Paul Merkley. Our very special guest today is Dr. Denise Connolly, professor in the Department of Physiotherapy at Western University in London, Ontario. Welcome, Denise.
Thanks very much.
Could you tell us a bit about yourself and what you do?
Right. So my clinical training is as a physiotherapist, and my research program centers on rehabilitation and physical activity to support physical functional independence in older adults, particularly in long-term care, which is what we're going to talk about today, which is our context for our current research studies. We've explored the concept of participation, and that is how residents of long-term care make meaningful involvement in a life situation for themselves while living in long-term care. I've studied the benefits of seated recumbent cycling for improved mobility, specifically walking and life space, strength training or lifting weights to improve walking and balance, and developed a self-propelled wheeling measure to assess mobility in older adults who use a wheelchair. And we also explored the validity and reliability of a 2-minute walk test for use with older adults instead of the 6-minute walk test as examples of some of the research we've done in long-term care. Our current research is in partnership with the Registered Practical Nurses Association of Ontario, known as RPN. RPN is the professional association for the approximately 45,000 registered practical nurses in Ontario. Examples of the kind of work that RPN does related to older adults includes their active engagement in the public inquiry into the safety and security of residents in the long-term care home system, advising the College of Nurses of Ontario on entry to practice competencies for RPNs, and advising the Ontario Association of Public Health Leaders regarding the role of registered practical nurses in public health. And just to give your listeners a little bit of explanation about what registered practical nurses do, they are one of the types of nurses in Ontario, and they commonly work in hospitals, schools, clinics, and the community to provide safe and general care to people of all ages. Registered practical nursing requires 2 years of a diploma program from a recognized college, and they must pass a registration exam, and then they're eligible for registration with a provincial college. In Ontario, our registered practical nurses have a relatively larger scope of legal practice compared to many other provinces. They are self-regulating, autonomous practitioners that engage in collaborative practice with registered nurses and other healthcare professionals on the healthcare team. And registered practical nurses provide basic bedside care for patients such as vital signs, prepare and provide injections, and assist patients with daily activities such as help with bathing and dressing, moving, and feeding. Our study involves a relatively large interdisciplinary research team, including Nancy Snoblin, a research consultant with RPN, Tracy Smith-Carrier, Diana Pearson, Anna Garnett, Samir Sinha, a geriatrician and director of geriatrics at Mount Sinai, Cecilia Flores Sandoval, a PhD candidate at Western, and a research assistant, Claire Wilson. She is a PhD, Dr. Claire Wilson, and a research consultant on the project. We have a number of people on our team representing registered practical nurses, including Jen Calver. She's a director of quality and long-term care. Samantha Salatino, she's an RPN and a quality and accreditation lead in the community hospital, and Sandra Osborne, an RPN and clinical educator in long-term care. And so the examples that I'm going to talk to you about come from our study, which is funded by the Partnership Engagement Grants, COVID-19, a special initiative through the Social Sciences and Humanities Research Council of Canada. And long-term care, for your listeners, are places where older adults can live and receive help with most or all daily activities and have access to 24-hour nursing and personal care assistance. Specifically, we appreciate the opportunity to talk with you today about our research on resilience related to resources and supports needed for registered practical nurses working in long-term care during COVID-19, as it has enlightened us about the impact of isolation on older adults.
Thank you. Thank you. No, this is helpful. Like it's a great introduction. And I'm sure everybody listening now is quite on board of the detailed discussion that will ensue. So, Professor, my question is that in your research, you must have come across senior isolation, and what are the pain points as per what you found?
Right. I think to begin with, we discovered, talking with registered practical nurses working in long-term care during the last year and a half of COVID, that there are a lot of factors influencing isolation, including fear, elements of trust, physical, emotional isolation, social, and with lockdown, the emotional deterioration that occurred, including loneliness and fear and mistrust, and the relationships that they had previously with their healthcare workers changed dramatically, as often these were the only other people that they interacted with, perhaps for several weeks under lockdown, for example. What happened, or what the registered practical nurses spoke about, was the emotional, cognitive, and physical changes that occurred with isolation. Isolation in long-term care. During lockdown, residents were restricted to their rooms, which sometimes were relatively small, 100, 120 square feet. Those residents who had COVID symptoms then sometimes were even moved from their rooms to other parts of the long-term care home where they could be provided care by a particular group of RPNs, nurses, personal support workers. The other element of isolation was that reported by the registered practical nurses about their own feelings of isolation. They were fearful for their families, bringing the disease home or bringing the disease from the community into the long-term care homes. And the personal protective equipment that was required and the processes, the additional precautions needed during providing care. Everything took longer. Everything was relatively impersonal. They wore gloves, human touch. They wore masks, so we couldn't see people smiling. When the older adults, when the families were asked not to visit anymore at the very beginning, the older adults only ever saw the people providing their care. And it was under personal protective equipment. So for those older adults that didn't quite understand what was going on with cognitive impairment, which is very predominant in residents in long-term care, it was really disconcerting for them.
Thank you. What's your vision for tackling, not just during COVID, but as you know, the question of isolation was before and will be after whatever point we get to. What's your vision for approaching that problem?
Right. We have three ideas about this. The first one is that we need to provide the care and support for the healthcare providers themselves. Our study explored resilience, personal, professional, and organizational resilience, and the healthcare providers, particularly registered practical nurses, pulled their energy from their own personal resilience. So all the coping strategies that these individuals demonstrated largely were due to their training, their character, their moral compass, their duty to care and provide care. And so it was they really went above and beyond their roles, and often had to take on many different roles because they were required to only work in one long-term care facility. So many are work part-time. So many have at least 2 places that they work at. They were asked to choose one long-term care home. And they went home sometimes and lived in different parts of their homes because they didn't want to take the disease home with them. Everyone was working longer hours. And so they were relying on the support from their peers and their colleagues in the home. Long-term care homes were not seen in the public as the heroes of COVID. You'll remember some of the newspaper articles that spoke about the heroes, the healthcare providers who were heroes. Those news articles tended to focus on hospitals, which of course did amazing work. Not to take anything away from them. The long-term care homes did amazing work as well, but weren't as recognized. So yeah, that's the first thing. Trying to figure out how to support and care for the healthcare providers themselves, because if they aren't taken care of, they're not able to provide the care to others. So that was the first element. The second one is that the organization needs to figure out how to support their workforce based on their geography and their culture and their community and all those sorts of social factors that go into what makes the home. And some of the items that were hoped to explore with the organizations themselves is how to include the healthcare providers at the bedside in shared decision-making, training on personal protective equipment, communication about what the changes are going to be and how the processes or policies might change, and pulling together as a team. Everyone was working as hard as they could. Administration was having to pivot several times, depending on what was going on at the time. So there were a lot of moving parts, and many homes did a really wonderful job. There were a few homes that experienced a huge amount of loss in their residents. And then closing the divide between the front line, the bedside care provider and management, to retain and recruit more of the healthcare. As you probably heard in the newspapers, our healthcare providers are tired. They're very spent, and many are retiring a little bit early because they're just exhausted. Staffing was very difficult. Staff was brought in from surrounding communities into long-term care homes, and so the continuity of care was broken a little bit at times. Residents didn't know the healthcare providers. And in long-term care, many of the healthcare providers have worked there for years and years, and the residents know them and they know the residents. But when you're bringing in people from hundreds of kilometers away to provide care, there's some discontinuity there, but it was needed because that was the situation at the time. The third idea we have is about creating a network of cross-sector collaborations between hospitals and long-term care homes. So if healthcare providers could bring healthcare from the hospital to the long-term care home, and then maybe from the long-term care home back towards the hospital, there would perhaps be some advantages in terms of the workforce, in terms of the family as partners, for sure, a supply chain of personal protective equipment, and then around training and education to use the strengths of the workforce in both settings. family as care partners is critical. The registered practical nurses noted the significant amount of informal healthcare that the family provided. It was very noticeable once they were asked not to come to the long-term care. Now that's changed a little bit more recently in the last few months. Several family considered essential care partners have received the training and education needed, and they come in and they're there as many days a week as they can. The last solution we were thinking about is more use of technology. There were some really creative solutions that the long-term care homes implemented, which were really phenomenal. Telephone calls once or twice a week for older adults in long-term care just is not effective. They need in-person connections, often with cognitive impairment, physical touch, and someone present with them is more how they respond positively and supported. But what we found was homes would have bought a Wi-Fi bumper so that families could be in the parking lots and they could use iPads and they could communicate so that they were visual as opposed to only by telephone. Having a huge television so that the older adults could see more of the whole person, it was very well received by them. And having some sort of way to connect visually, so through windows, in the atriums, when the better weather outside, all those kinds of things were really important. So the healthcare taking care of the healthcare providers first so they can take care of others, encouraging organizations about how they could support their workforces, creating a network through cross-sector collaborations, hospitals and long-term care partnerships, and then increasing the use of technology.
Thank you. I think what you shared is so heart-touching. It's factual, heart-touching, and so important. And given that you have really ironed out the solution in a very easy and simple language and very detailed manner, what are the opportunities and challenges you're perceiving in this?
Right. Some of the challenges are the discontinuity in the care. So with staffing and people getting burnt out, there needs to be, and only being permitted to work in one long-term care facility at a time, somehow supporting the healthcare providers, specifically the RPNs, in more than part-time would be really helpful, and that training more people. Challenges, the other one that we thought was a big one is the families as care partners and their involvement. The families are really important because with isolation, the behaviors, self-expression of the older adults changed, and not always for the better. So when they're confused, or when they're not quite understanding what's going on or need reassurance, the family knows them and can help with consoling or providing support to the older adults, because they know them. They know if they like music, they know if they like to be read to, they know if they like to watch a particular show, those kinds of things that are important to them, which is really helpful. So trying to figure out how to get the families back in a safe way would be one of the challenges. So the other thing is that some of the older adults, because the staffing was difficult, because Some of the other staff was not allowed to go into long-term care. So occupational therapists, physiotherapists were not permitted. Recreational therapists were not considered essential. And so you've got a lot of people with a lot of free time and not cognitively or physically engaged. For example, people who were walking before COVID are now using wheelchairs because with so few staff, you can only do so much, right? And the ratios, often you will have 10 or 12 people in your care, and everyone needs to eat. The basic activities and the basic needs need to be addressed first. So toileting, bathing, feeding, those kinds of things. And the RPNs would take more time with the residents because they knew they were lonely and they needed their hand held and they needed someone to talk to or to spend some time with them, because otherwise they spent most of their time by themselves. So they were eating and sleeping in their own rooms sometimes, until some of the restrictions were lifted, and then the homes made very creative strides to bring people back to the dining room by under observing the health and safety, but still it was tough. It was really tough. And then the cognitive decline was really observable. People didn't have the conversation, didn't have the engaging social activities and those kinds of things, and they really declined. The other thing was that the residents gave up because they didn't understand why their families weren't calling, why their families weren't visiting, and so it was really difficult. The moral distress that occurred among the care providers, the healthcare workers, was really relevant. They were, of course, trying to do their very best by every resident. And so when they only have so many hours and they have to do so many things that they weren't able to provide sometimes all of the things to all of the people that they wanted to. And so that caused them a lot of distress, and they witnessed a lot of death in some homes, and sometimes they had known these people for years and years and years. So that was really hard on them as well. What we've seen is that also when people were looking at COVID globally, it was really disheartening. Because there seemed to be very little that people could do. So one of the things that we thought about was seeing COVID at a community level, which empowers people more, because it's, okay, this is what I can do here in my community, and taking action to provide people with hope, as opposed to globally, where it's, it sometimes leads to feelings of helplessness. And so that was one of the challenges that we thought was perhaps the beginning of an opportunity, was to look at things more on a community level. And then the other opportunities were that the registered practical nurses really stepped up to the plate and took on leadership roles and other roles that they weren't necessarily specifically part of their training or education, but they are resourceful, and they're really, the duty to care was really strong in the research findings. And so they would try most everything that they possibly could. So they were using iPads and taking them to residents' rooms. They were calling residents' families on their personal iPhones because that's what they had available to them, and trying to facilitate those conversations between the family and the residents. The other opportunity was families as essential care partners, and as partners on the healthcare team. So reconceptualizing how families are part of the healthcare team and the importance of that, and not reporting to the family, but rather including the family in the healthcare circle discussions. And it's going to require some rethinking and changes in culture, and maybe a bit of training, because as we're trained health professionals and we do our jobs when we're in the clinical setting. And then as soon as we're in another situation where we are daughters and sons or spouses of someone receiving care, it seems the emotions get the better of us, perhaps on occasion, as opposed to maintaining our professional roles. So it just depends on the situation, right? Which is interesting, because we can function as physicians, as physios, as social workers, and be very effective and have produced good outcomes for our patients. And then as soon as we're in it on the other side of the fence, it's a little different. So, but we're human. The other thing is that we wanted to advocate for older adults and the importance of providing safe and high quality care in long-term care homes, because there's been a call to address long-term care home situation 20 years ago. And so here's a golden opportunity to really advocate and to really make some good changes in the long-term care home system. And there's a lot of good work that's beginning across the country. The other thing that we were thinking about in terms of opportunities is the curriculum of the registered practical nurses in the colleges system, and to identify some of the roles and leadership and those kinds of things that could be added to the curriculum, and to serve them very well.
Thank you. Thank you. What advice would you have for a company like ours?
Right. So this was interesting. So our team reflected on this, and what we came up with was focusing on the policies and the standards, education and advocacy. And I think it sounds like that's exactly the kinds of things that your company is doing. We encourage you to engage seniors and residents themselves and spouses or partners in the discussions. We discovered that it's a little bit different for spouses versus the children of the residents of long-term care, because as children of older adults, we may not see our parents every day. We might see them at different frequencies depending on the physical distance of where we live, or we may talk to them on the phone, or FaceTime, or share stuff over Facebook and things like that. But as a spouse of someone who is now a resident of long-term care, you did see that person 24/7. You shared a home with them, and now they're in long-term care. And on Thursday of March 2020, you were told you wouldn't be able to see them. And you didn't know how long that was going to be. And so that was really something that we hadn't actually thought about going into this research. So we were really glad. So we encourage you to engage seniors, residents themselves, spouses, and partners in your conversations. The other thing we're thinking, oh, sorry, we have one more, is awareness around dementia and what that means, hearing and visual problems. Older adults who are residents of long-term care are not necessarily older versions of you and I. They have multiple health conditions. That's why they require nursing care. And the layers you don't get to be an older adult without being tough and pretty resilient and stubborn maybe a little bit. But there's a great book. It's called Growing Old is Not for Sissies. And so it's just important maybe to think about the multiple layers that normal aging, and the impact it has on older adults and not just older versions of ourselves. So there's levels of vulnerability and feelings of isolation, feelings of loneliness, and maybe a bit of disconnectedness, depending on what your social support system is like, and the long-term care home itself, and the administration, the physical residence, and it may be not where the person lived most of their life either. Sometimes families will bring their parents closer to themselves, which means the parent leaves their community, and they may have their friends. That group gets smaller. Growing older is all about shedding and losses, lots of losses. So just being aware of those kinds of things.
Thank you. Thank you. And if people want to find more about you and your work, how can they look you up?
Oh, right. So we have research pages on the University of Western Ontario website. So if you just put Denise and physiotherapy and Western in a search bar, you will find me. So there's that, and my email is there, but it's dconnell with 2 L's at uwo.ca. So yeah, it would be great if anyone would hear more about what we do.
I think I really was emotional at the same time listening in so carefully on this episode. Like the work you do and you've done is fantastic. Thank you so much. It was very, very educational for me. Thank you so much.
Thank you.
Thank you. This has been a wonderful opportunity, and good luck with your work.
Thank you.